Hello, hi everyone. So thanks for joining us. We'll be starting in a few minutes. I request all the participants to please keep your mics off.
Purva is Sir here.
I can't see him, but I'm trying to. I think he has some problem with the audio. So.
All right, all right. Okay, guys, we'll wait for 5 more minutes. I think that by that time, problem will be resolved. Please be patient. Thank you.
Yes. Hello. Hi, sir. Am I audible?
Yes, am I audible to you?
Yes, sir. Yes, sir. And your screen is visible as well.
Yes, great. So it took me some time to log in. Sorry for the delay.
Right. Fine. All right. So let's start it. Hello and good evening, everyone. Welcome to Meducation 2020. I'm Purva and I'm your club service director. Today, I welcome here on our platform our eminent speaker, Dr. Sushant Shinde, who will enlighten us about the basics of bedside medicine and history taking. Dr. Sushant Shinde is a consultant rheumatologist in Mumbai, and he's also the founder and director of Quest Medical Academy. He has inspired so many students across the country, me included, and we are so thankful to him. It is our pleasure to have you on our platform, sir. Without further ado, let's get started. Over to you, sir.
Okay, thank you so much, Pura, for your kind introduction and for this invite as well as your organization. And thank you for all the participants who are here right now. I would really like this to be an interactive session as far as possible. I have a quick question for you, Purva. Can I share my screen right now?
Yes, sir, I think you can.
Just give me a second. Just going to try something. So are you able to see my screen right now?
Yes, yes. I can see the screen.
Okay. Okay, sorry, I should have tried that earlier before I start. Okay, so it's a very interesting thing that the topic that you have asked me to speak on, and it's something which is also, of course, very close to any clinician's heart. And as medical students, I am sure that a lot of you are right now concerned about this fact that how are we going to develop our skills about history taking, given the fact that thanks to COVID and the kind of aftermath of it, we are not able to reach our hospitals, we are not able to meet patients, so on and so forth. It's also very interesting that in the last 7 or 8 years that I have been teaching, this is the first time I have been ever invited to talk on this topic. The kind of the paradox is not lost on me that when the time was there when we could meet patients, nobody invited me to talk on a topic that how do we take better history and how do we become better at bedside medicine. But now that we don't have that opportunity, I would really like to highlight this that this might be the right moment to think about how do you take your history and also to realize the importance of that part of our curriculum, that part of our education where we get a chance to go to the wards, meet patients, and whether we like it or not, there is a good chance as students we don't really enjoy that part a lot. because it makes us feel a little lost. We go there and we try to talk to these patients, and some of them answer things which you don't make a head or tail out of. What are they really speaking? Does this really mean anything? सच में बीमारी है कि नहीं है? And अगर है तो जो मुझे लग रहा है वही है क्या? And then eventually, of course, the boss comes in, some consultant comes in, and the patient seems to always change the history and tell something new to the doctor, and which you were not aware of. So things like that happen. So ward is a very interesting place. But nevertheless, that is what we are here to do. As in clinicians, most of you, I'm sure, will be clinicians. Some of you would take up branches which are not directly patient interacting, but majority of you would take up branches which are directly dealing with patients. So how do we go about this idea of history taking? Without a doubt, it is an art as well as science. To approach it in a very scientific manner would be to do injustice to it. I truly believe it is an art in which you need to gain your patient's confidence and also keep on thinking. So the right and the left side of your brain needs to be working simultaneously when you're doing this. Uh, there are going to be few rules which I believe might help you. The way I'm going to proceed is in the next 15-20 minutes, I'm going to lay out what I feel are going to be the important aspects. There are going to be instances where you thought you were stuck in history taking. There are things which you want to clarify. I would like to take your questions after I've done speaking for 15-20 minutes, right? So, first things first, when you're going to be in the ward, whenever you're going to be taking history, remember, history taking is you being Sherlock Holmes at that time. Think of yourself like that at the moment, right? When you're going to be in front of the patient. Then your only clues is what your patient says. So you should be encouraging the patient to speak as much as possible. If your idea is that history taking is me asking questions, there is a good chance that you are going to miss out the clues which were supposed to be there. The clues are not in your questions, the clues are in what the patient has to see, right? So allow the patient to speak. So if I'm to write down this, and I'm going to share my screen here, again, these are not really rules written somewhere. These are more of thoughts which I feel might help you tomorrow. So if I'm to write down what I feel are the golden rules, so to say, of history taking, I would say the first golden rule is, without a doubt, listen to your patient. Now, what do I mean by this? When I say that you need to listen to your patient, I truly mean that when the patient starts speaking, you need to allow the patient to complete. There is a very interesting rule of how to develop your patience when someone else is speaking. The idea is when someone is speaking to you, let that person complete, and just when you feel that he has or she has completed speaking anything, start counting in your mind up to 5. ऐसा ना हो जाए कि the person is thinking and is about to say something else and you interrupt, right? So do that, follow that rule even during history taking, that let the person complete. One of the good ways of allowing the person to complete is your posture, right? How do you stand when you're taking history? How do you sit? How are you? Is the conversation, is the whole layout very comfortable for the patient to speak? Let me just give out a very simple idea. Let's say that you are, right now talking to me, even on this video conference platform. Right now, thanks to COVID, all my patients are right now being seen via telemedicine. So I'm completely aware that right now, if you're looking at me, if you're looking at the screen, I'm looking at you. That's because I'm consciously, deliberately looking at the camera, right? Imagine for the next 2 minutes, I look there and I keep on talking to you. It just doesn't make any sense. You would not be interested in talking to me after a certain point if I don't look at you. If you want your patient to speak the complete story to you, you need to be very attentive. Your body language matters. Are you looking at the patient or are you looking at your textbook? Are you looking at some question to see next line mein mere ko ye sawal puchna hai? If that's what your intention is, the patient will read your mind. He will be very sure that the moment I finish what I have to say, he will ask me a question. He's not interested in what I'm saying. He or she, the student, is interested in asking me new questions. Doesn't make a lot of sense. Doesn't inspire a lot of confidence. So when you start your history taking, go with an open mind, with a single minded agenda. I want to listen. I want to listen what you have to say, right? Be inviting in that posture of yours, that gesture of yours. Have a good eye contact. Do not carry books and hold those big books in your hand at that moment when the patient speaks. You will get a chance to do that if you want to, but this is not the time. The first time that the patient speaks, listen completely. Why do I listen? I mean, I said it's an art and it's also a science. So the art part is that you need to listen, but there is to be a science part to it. What am I really doing when the patient is, yapping around and telling me everything? So, for example, you might have a patient who has some really bad disease according to you. You already know, you have seen the file and you think that this patient maybe has MI, maybe this patient has a coronary event, maybe the patient has a stroke. And when you start listening to the patient's story, the patient might start with the story, कल सुबह मैं उठा था, and you are like, अभी कल सुबह से अभी सुबह तक का कहानी सुनाएगा तो बहुत कुछ सुना देगा. And yet you need to be patiently listening to it. Why did I do that? The art part is good, I need to listen. What is the science behind it? Well, remember, the science is very simple. You are trying to localize which system disease are you dealing with. So when you're listening, what's happening in my mind is all throughout that the patient is talking to me. On the other side of my mind, I'm working out which system am I dealing with. Maybe someone has told me this is stroke, but there is a good chance that in most of the times you don't know which system you're dealing with. So while I'm listening, the parallel for me is which system. For example, the patient might tell you the first thing that comes out of the patient's mouth is, I have dyspnea. Maybe that's what you heard the first. Now, if you're very tempted to start thinking of dyspnea at this moment, you would be very tempted to say, अच्छा ये तो cardio ही होगा या respiratory होगा, right? But if you start listening to the patient further, and if you listen to the entire history, maybe the patient will say, well, I have dyspnea, and I also have ascites, and I also have jaundice, which had happened maybe last month, and I also have maybe pedal edema, and you know what? I have also bled, I also had an upper GI bleeding. Now, all of a sudden you say, no, 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 it's not cardiorespiratory. Actually, it looks like the patient has cirrhosis. If I do not listen to the patient, I miss out. So while I'm listening, remember, the first time that you listen to the patient, that is the time you're trying to conclude this in your head. Which system am I dealing with? I personally do this, and I love to think that way. I think of Harrison's or whichever textbook of medicine that you read, the first few pages, the content page. Think of it. If you're dealing with a patient in medicine, where else is the patient going to come from? He has to be one of the pages of Harrison's. If you're talking about a surgery patient, he has to be coming from one of the pages of Love and Bailey. Of course, I'm not saying that every patient would be mentioned there, but I'm saying at least the system. I need to be aware of the system that I'm dealing with. So when the patient starts speaking, I start listening and I would listen to the entire story, trying to figure out which system. Once I know the system I'm dealing with, right, that's when I start questioning. Now, I know that all of us have been told that, well, we have to take the name, age, gender, occupation, and then we go into the chief complaints and all of that. I'm not even going there. I want to highlight this, that all that you were taught and how you present in your vivas, that is a way of presentation. That is not to be confused with the way of history taking. Please do not confuse this, that when you see patients, you are supposed to start by asking, okay, tell me, are you a right-handed or left-handed patient? Where do you stay? What is your age? What is your, no, maybe gender you are aware of, but what's your complete name? And then you start asking, अच्छा आप बताओ क्या हुआ है? You have already lost the patient's confidence in you. The patient did not come there to tell you कि मेरा नाम ये और मैं वहाँ रहता हूँ और मैं यहाँ जाता हूँ. You are eventually going to ask those questions. It is not necessary that you ask them right in the beginning of your history. It is necessary that you write them at the beginning of your history when you're presenting to your examiner. That's not same as what you do with the patient, right? So when I see a patient in the OPD, I mean, all of you have gone to some other doctor as a patient as well, right? So did the doctor start with, अच्छा बेटा बताओ तुम्हारा नाम क्या है और तुम्हारे रहते कहाँ हो, पूरा पता बताओ, उसके बाद ही पूछूंगा तुमको हुआ क्या है. The patient is coming to you because of a symptom. Ask about that first. Listen to the whole story, localize the system that you're dealing with. What next? This is when you start talking. Till this moment, keep quiet, right? It's very important for you to keep quiet and listen to all the points. Also, while you're listening, mark out the odd features. For example, I heard the entire story of this patient having ascites and pedal edema and jaundice and all of that, but something did not fall in place. I still do not know this jaundice that happened, maybe, as an example I'm taking, this jaundice that the patient is talking about, maybe that jaundice was something which doesn't fit into the story. Maybe what I'm really suspecting is this person looks to be alcoholic to me. Maybe he has an alcoholic liver disease, but he never mentioned alcohol. Maybe the jaundice he's talking about, he mentioned it was 15 years back. 15 years back ka jaundice tha, ab ascites kaise ho sakta hai? So there are going to be things that the patient is going to say which will get you to refute your diagnosis. What does that mean? So the first thing I did is I tried to figure out which system. But simultaneously, the other thing I'm going to do is I'm going to try and refute that system. That means while I was listening to the patient's story, I thought that there was some system involved. But when I start asking the questions, some of the very first questions I'm going to ask is I'm going to ask him about his symptoms especially that symptoms which helps me to refute whatever I've thought. It's like a balancing act. It's like my mind is going to play two things together. On one side of my mind, I'm going to try and say, okay, I'm dealing with maybe respiratory case, or maybe I'm dealing with a cardio case, or maybe I'm dealing with a gastro case, whatever I have thought about. The other side of my mind is going to say, nahi, 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 ye case nahi hai, kuch aur hai. I have to keep on doubting my diagnosis and keep on asking questions which are negating out these doubts which come to my mind. So if I start thinking this is a cardio case, I'll ask the patient, oh, Achha, you said you have dyspnea. Do you think the dyspnea is on exertion? The moment he says, no, 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 there is no dyspnea on exertion, he has told me that I'm not dealing with cardiorespiratory case. I'm maybe dealing with dyspnea of some other cause. Maybe I'm dealing with a psychogenic cause. Maybe he's not having dyspnea at all. What he's talking about dyspnea is more of fatigue, right? It's not dyspnea. You know, those of you who are aware of this, if you take history in Marathi, you ask the patient, dam lagto ka? Very often patient says yes. Dam lagto ka can mean dyspnea. But very often the patient thinks dam lagto ka means damta ka. Damta ka manje, are you fatigued? So this might be a simple, wrong thing that you got. You ask the patient, do you get more tired when, do you feel more dyspneic when on exertion? He says no. You know that you are ruling out the system which you thought first is most likely system. So go in a balancing act. Listen to the patient, figure out a system, and then ask some key points to try and refute that system. The moment you are able to refute that system, you need to listen to him more carefully. You need to listen to him again and ask him more leading questions to figure out which system am I dealing with. If you make a blunder here, then you are off for a toss. Very often when I have case discussions with students, when I listen to some of the patients who come to us who are completely off the track, the previous diagnosis that was labeled to the patient was completely off the track. One of the commonest mistake is this system was not thought of. I'll give you an example. Just before this conversation has started, the last patient I saw today was a patient who came to me with a digital infarct. Her finger was having an infarction and she had visited a surgeon. This is a real example, just half an hour back patient that I've seen. The lady had a digital infarct and she had gone to a surgeon to get that gangrene corrected. Now, hats off to the surgeon because the surgeon figured out this was not her first infarct. She has had multiple such infarct in the past. And every time the infarct was happening during winters or any season. That got the physician, the surgeon thinking, am I really dealing only with a local problem or some bigger problem? Remember, the previous surgeons she has met have all operated for whenever she had an infarct. She in fact had other symptoms also for which she has met other doctors. Everybody was localizing to a system which according to the history was maybe just this much. But when this particular surgeon asked more questions, she realized that this particular patient has digital infarcts, also has skin tightening, also has mouth that she cannot open, also has breathing difficulty, also has Raynaud's phenomena. So many things which can't be explained by just as a case of local problem. She thought of systemic sclerosis, referred her to me, and guess what? Her investigations are compatible with systemic sclerosis. Remember, her presentation is just an infarct. If you ask her what's your problem, she tells you just this is my problem. But if you ask her, do you have anything else? Well, she tells you many other things. Yes, I have this, I have that. You put all of that together, you get the right system. As undergraduates, especially if you are in second year of MBBS or third year of MBBS, I think this should be your priority in history taking. Which system are we dealing with? But those of you who have reached the final year, and if there are by chance any interns listening to this, or whenever you become interns by that time, then you start dissecting out within the system which is the most likely pathogenesis or area of lesion that you're dealing with. Let me give you an example again. So for example, if I'm dealing with let's say cardiorespiratory case, if I'm dealing with a cardiorespiratory case, so first I thought of the system, I took better history to refine that system. Third, I'm going to say what is the pathophysiology, or what is the site of lesion, where is the problem that I'm dealing with. For example, let us say that after listening to the history, I'm sure that I'm dealing with a case of CVS. Now, what do I mean by pathophysiology in CVS? I would be very interested in knowing if there is a problem in the heart, where is the problem? Is the problem on the side of LV, LA, or is the problem on the side of RV, RA? Well, there would be different symptoms. I'm assuming that most of you are oriented to clinical medicine, so I'm just going to quote these examples. That if I have a left-sided disease, I expect the patient to come with breathlessness. If I have a right-sided disease, I expect the patient to more often have pedal edema, raised JVS features. If I have a patient having left-sided disease, I expect risk factors like the patient having systemic hypertension or coronary artery disease, dyslipidemia, so on and so forth. If it is a right-sided disease of the heart, I expect the patient to have diseases of the lung causing cor pulmonale like COPD or XT. Right? So I would want to further delineate what is the site. Once I know the system, I'm interested in the site. I would also be interested in what is the pathophysiology. For example, once I have said that it is a disease of the left side of the heart, I would be further interested in knowing, am I dealing with a valvular heart disease? Am I dealing with a congenital heart disease? Am I dealing with a coronary artery disease? What type of a disease am I dealing with? Remember, each of them will have their separate history taking. You will ask for those leading questions to go there. Do not ask for leading questions because I read in a textbook that I'm supposed to ask for syncope, angina, dyspnea. Don't do that to yourself. Think before you ask, and then let there be a reason why you asked. The way you ask is your art. What were you thinking? That is your science, and keep it always together. Right? Keep it always together. This balancing act of science and art that goes together in history taking. Let me take another example. Let's say that you were thinking not of CVS, but you're thinking of a case of CNS. Again, the same principle. You will have to think in terms of site. When you think of site, you might be interested in, am I dealing with something like CNS or central nervous system disease, or am I dealing with something with peripheral nervous system disease? The symptoms are going to be different. If a patient tells me I have a seizure, I'm not going to think of diabetic neuropathy. But if the patient tells me I have burning sensation in both of my feet and that's all that I have, I'm not going to think of stroke. I'm going to think of diabetic neuropathy. So what is there in the history? I'll have to localize where is the cause. But after that, I do have to think of pathophysiology. That means if I'm thinking of a patient coming to me with seizure, I will have to think, is this seizure because of something like tuberculosis? Let's ask relevant questions. Is this seizure because of something like neurocysticercosis? Let's ask relevant question. Is this seizure because of something like he has intracranial hemorrhage? Let's ask relevant questions. Because each of them is going to have a different trajectory. A patient with TB will have features of fever, anorexia, weight loss. A patient of NCC, really speaking, would have no other features. Patient of intracranial hemorrhage might have features of raised ICT, might have features of bleeding in form of other neurological deficits, so on and so forth. Right? So history taking, after the first point of localizing the system, is about localizing the pathophysiology and localizing the site of that pathophysiology. But once you're doing that, my rule number 2 again comes into place. My rule number 4 is going to be try and refute it. The moment you try to convince me that this is a patient having maybe a coronary artery disease. Purva, I'm getting this request over here for annotation.
Yeah.
Decline or approve?
Yes, decline.
Okay, yeah. So where was I? Yeah. So my rule number 4 is going to be very simple. Whatever I have done till now, try and refute. Remember, most of you will find this step difficult because let's be very practical at this stage in the career. To reach a system is going to be a tough part. Then I'm saying after you have reached a diagnosis, try to refute the diagnosis yourself. Then I'm saying try to localize a pathophysiology. But once you have reached a pathophysiology, try to refute that pathophysiology. For example, I might want to say that my patient has coronary artery disease. But if I want to refute that my patient has coronary artery disease, I would want to ask more questions. For example, do you have angina? Do you have features of angina and exertion? Did you have a past history of coronary events? Do you have a family history of coronary events? Is this person obese? Is this person a smoker? These factors help me to either make a diagnosis or break a diagnosis. That brings me to the rule number 5. If everything that I'm going to say, everything that I'm going to think, I have to refute that. How do I reach this idea? How do I reach the idea of that I can refute a particular diagnosis? How do I reach the idea of making a particular diagnosis? Most of us will find this difficult initially, but later on I can tell you this is something you will do every day. The key word to learn how to reach a diagnosis and how to refute the diagnosis is something you'll have to do before you go to the wards. Something that you do when you are reading your textbooks. So let me tell you something very interesting. If you start today reading cardiology, let's say you know that you're going to get a cardiac case, so you start reading cardiology. most of you would start reading by picking up a chapter. Let's say you pick up a chapter of valvular heart disease. You read through the etiology, you read the clinical features, then you read through whatever investigations and management. Maybe you have more time at disposal, so you pick up coronary artery disease, then you go read through the ECG findings of coronary artery disease, then you read through all the clinical features of coronary artery disease, then you go through investigations and management. But at the end of it, when the patient comes in front of you, how do I differentiate whether this patient is valvular heart disease or this patient is coronary artery disease? Both of them can tell me dyspnea. Both of them can tell you that I feel fatigue. Both of them can tell you syncope. One of them might tell you angina, but if he doesn't tell you angina, does that make him valvular heart disease? Not really. What is the key to refute? The key to refute is when you learn and pay attention to a word called natural history. This is one word of studying, technique of studying of medicine, which I know really feel someone would have told me much earlier. I realized this when I became a resident, and I guess most of us learn it when we are residents, but that really makes our history taking very poor when we are undergraduates. So I would want you to pay attention to this idea called natural history. So what really is natural history? So the key word here, my point number 5, is that when you learn, if you want to become good at history taking, you need to know natural history of diseases. What really is natural history of diseases? Whenever you read the clinical features part, so let's say this is something that happens when you're reading the theory of a particular chapter, right? Now, what I'm trying to say, this is perhaps the most important part of my entire, monologue to you, that whenever you're trying to read the theory, if you want to connect your theory knowledge to what happens in the wards, this is the key, understanding the natural history. Remember, all diseases have 3 important aspects of reaching diagnosis. One are the risk factors. For example, you might have a patient who is a smoker. You might have a patient who is an obese. We might have a patient who is diabetes, puts him at a high risk of coronary artery disease. But you might have another patient who is young, who is a male, who has a past history of acute rheumatic fever, puts him at a risk of some completely different disease. You might have a smoker who has no other risk factors but is a heavy smoker and has come with some other clinical features, might make him COPD. So risk factors are something you need to study very carefully when you're reading a particular disease as the theory topic. Second, of course, is clinical features. This I don't need to highlight because I know all of you pay attention to this, and you hope that when I know the clinical features in history, when I read the theory, when I go to the wards, this is what the patient will say and I'll make the diagnosis. But there's a problem. When you know the clinical features, think of respiratory system. क्या ही clinical features होंगे patient को? अगर patient आया जिसको pulmonary problem है, the only few things that the patient can tell you is dyspnea, cough, and maybe hemoptysis. That's about it. Sometimes pedal edema, sometimes something else, right? So almost all patients of pulmonary system tell you that I have dyspnea and cough. But a dyspnea and cough can mean COPD, a dyspnea and cough can mean bronchiectasis, a dyspnea and cough can also mean CLM, a dyspnea and cough can also mean pleural effusion. So if your way of studying is to focus on clinical features, you're going to very likely miss out the diagnosis when it comes to history taking. This is very common. Most of us focus on this when we are reading the theory. We don't pay attention to this, right? But if you tell me that you have a patient who has dyspnea and cough and along with that is a smoker, well, that means something. If you tell me that the patient is dyspnea and cough and has a exposure to tuberculosis, that means something else, right? So pay attention to the clinical features. In the clinical features, especially I would say there is one part that you should pay attention to understand the natural history, and that is the sequence of events or chronology of events. Always know when you're writing down your notes for a particular disease, try to write down whether that disease progresses in minutes, hours. Does it progress in a matter of maybe hours to days? Does it progress in a matter of weeks? Or does it progress in a matter of months to years? How long is the history before the patient comes to you? Remember, if a patient has come to me saying, I have shortness of breath since last 1 hour, I'm not going to call him as bronchiectasis. I'm going to think ये asthma होगा, ये COPD का exacerbation होगा. But if someone comes and tells me 6 महीने से सांस फूल रही है, I'm not going to say 6 महीने से सांस फूल रही है तो asthma होगा 6 महीने से. I'll say 6 महीने से सांस फूल रही है तो COPD शुरुआत हुई है, या bronchiectasis है, या pleural effusion है 4 महीने से 3 महीने से. My diagnosis will change. So always pay attention to the sequence of events and how long does it take for the patient to come to you. So read your risk factors, read your clinical features. And the third part, which again a lot of us kind of don't pay attention when we're undergraduates, is what are the relevant investigations? What are the relevant investigations to make a diagnosis? Now, I know a lot of us are taught you don't read the file before you go to the patient, and I agree with you. But do not confuse the story. Don't read the file before you meet the patient is not same as don't know what has been done before you met the patient. If a patient has been hospitalized in your hospital for 5 days, his presenting symptoms very likely have been sorted out. If he came with dyspnea, most likely that dyspnea is gone. If he's still in the hospital, it's because something else is unsorted. Now your job is to figure out why is that particular thing unsorted. Not to figure out only why there was dyspnea, but also why whatever has not been sorted out is not yet been sorted out, right? If a patient has gone to 10 doctors or maybe 2 doctors before he came to your hospital, why did he come to you? Were the 2 doctors who met them before reaching your hospital, were they incompetent? Not really. Either they made a wrong diagnosis, but that's not so common, or the patient had something very peculiar that he did not respond to those therapies. If you don't pay attention to what was done by the previous doctors, it's very likely you are going to repeat the same mistakes. You're either going to make the same diagnosis or you're going to start the same therapy. So I agree, do not read the file, but do not confuse as not reading the file is equal to not knowing what has been done before you. Do not read the file means do not accept the diagnosis which has been offered in the file. That is okay. Always try to refute. That's the key, right? Always try to rule out in your mind, why is it not this? How can I prove it is not this, right? And take the history in further details. But you need to know what investigations have been done. For example, if you have a patient comes to you with shortness of breath and already has an ECG which showing atrial fibrillation, you in all your glory deciding that I will not see the file doesn't help the patient in any way. You are not there to serve your purposes. You are there to serve the patient's purpose. Remember, that's why you're listening to the history. So if the patient tells you, मेरा ECG हो चुका है, doctor साहब देख लो, and you saying नहीं मैं file नहीं देखता, who's lost? I mean, nobody gains out of it, right? So let's be very clear. Look at all the investigations that have been done. I should tell you, as a resident at AIMS, अभी कम होता है, but AIMS gets, I mean, as residents in most of the colleges actually, you will get a lot of referral patients. Go to the wards whenever your wards open up and see how many bundle of investigations they are carrying before they reach the hospital. Patients in India do not come to big gigantic government hospitals for the first time that they have the disease. They come when every other resource is over. That's when they come to you. So someone has seen them before you and has done a lot of investigations. Go through that file. That will teach you a lot of things. Those previous investigations will teach you a lot of things. Especially they'll teach you what should be done and what should not be done, and they will tell you the natural history of that disease. If a patient who comes to you and has been repeatedly having these bouts and multiple times people have seen, ask them what happened over there. Ask them, when someone gave you this drug, did you improve? If he says yes, I improved on diuretics, you know diuretics he seems to be responding, looks like heart failure. But if he says diuretics से कुछ फर्क नहीं पड़ा, वो पम्प दिया तो उससे बहुत आसान लगा मुझे, you know you're not dealing with heart failure or maybe dealing with something having obstructive airway disease. All those investigations, all those nuances which have happened before he came to you are important. My request to you is, do not confuse how we present the history with how do you take the history. Taking the history is this game of you asking the right questions and trying to refute in your mind, is this? No, 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 it is not this. How do we end this story? What do we do after we have collected so much information? I think after you have collected all this information, you need to draw a very clear flowchart in your mind and preferably on paper as well. This is something again I learned, or rather mastered. Not mastered, not a good word, but I kind of refined for myself during my residency. And I know for sure a lot of my colleagues have also done that. A lot of practitioners do this without actually thinking that they're doing this. That is, we make a flowchart in our mind and we end that flowchart of this is the diagnosis, नहीं नहीं ये नहीं है. This is the diagnosis, नहीं नहीं ये नहीं है. ये भी हो सकता है, but नहीं 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 ये नहीं है. And this we summarize as points in favor of and against. For example, if I have taken a history of a patient and that patient has come to me, I'm sorry. I'm sorry, I did something wrong somewhere over here. Yeah. So if I've taken the patient's history and at the end of the patient's history, if I have realized that what I'm dealing with could either be coronary artery disease or the patient could be having a valvular heart disease, right? What I need to do at the end of it is I need to write down what are the points in favor of valvular heart disease, what are the points in favor of coronary artery disease, and I need to write down what are the points which are not in favor of coronary artery disease and what are the points which are not in favor of valvular heart disease. Learn to do this exercise. This will not only improve your analytical skills, this will also give you a good way of summarizing everything. You might also figure out once you start writing down, अरे ये सवाल तो पूछा ही नहीं, अरे ये भी पूछ सकते थे. For example, you might have asked about angina over here, that goes in favor of this, but you do realize अगर angina है तो इधर भी एक angina का cause हो सकता है, which is aortic stenosis. और अगर aortic stenosis है तो उसको syncope हो सकता है, अरे वो तो पूछा ही नहीं, चलो syncope पूछ लेते हैं. And the moment he says syncope, this goes higher up, this comes lower down. Are you getting it? So you need to start writing down your history in terms of what goes in favor of a particular diagnosis, what goes against a particular diagnosis, right? With that, I think I have kind of given you a nutshell, in nutshell, what I feel is the right way to approach patients. I repeat, I think the best way is to try and take the history and listen to everything that the patient has to say. Try to narrow it down to a particular system. Then again, try yourself to refute it. Then try to narrow down to a particular pathophysiology or to a particular site of disease. Ask relevant questions for that pathophysiology or for that site. Again, try to refute it. And while you're doing all of this, remember the natural history of the patient. And the natural history comes from what risk factors the patient has. So ask those questions. What clinical features and what timeline that particular disease behaves like, ask those questions. And what investigations or treatments the patient has got before he came to you, ask those relevant questions. All throughout, maintain good eye contact. All throughout, convince the patient that you mean to listen to him. It is okay if the patient knows that you are not the treating doctor. A lot of us believe that as students that अरे patient को तो पता है मैं doctor नहीं हूँ, इसलिए मुझे कहानी नहीं सुनाएगा. Wrong. In fact, all patients would want to talk to you because they hardly find anybody interested in listening to them, right? If you are ready to listen, they will tell you a lot of stories, right? But be ready to listen, right? Improve your skills of listening. I would end by this one simple example. One of the best ways to learn how to listen is start taking history by that case which is not your exam case. Because if it is an exam case, you are going to be very tempted to ask the right question. Checklist होता है ना दिमाग में, ये भी पूछना वो भी पूछना, अरे इसकी हिस्ट्री पूछी क्या, उसकी हिस्ट्री पूछी क्या. Start with a non-exam case. Start with someone you know कि इसकी हिस्ट्री से मुझे कोई फर्क नहीं पड़ता. तब भी अगर सुनना सीखोगे ना, तो जो एग्जाम केस है उसमें भी सुनोगे, right? Start with those elderly babajis and matajis who are sitting in the wards chit chatting somewhere. Go and talk to them, right? Learn how to listen to them, and you'll develop your empathy. You'll develop the right skill set, which will kind of enhance your history taking later in life, right? So with that, I think I'm done with my ranting. I would like to take your questions, whatever way I can help. So over to you, Puru.
Okay, guys, if you have any questions, you can type it down, or if anyone wants to talk, they can also unmute at this point. Okay, so we have a question for you, sir. How do you talk to delirious patients? I mean, does the whole listen to your patient first work in this case?
Okay, so that's a good question, Akshaya. Uh, if we are talking to a delirious patient, then that's a lost cause in most times, because the delirious patient, by definition, doesn't know what he or she is speaking. So there are two options. If, for example, I have a delirious patient who has come in the OPD, my priority is get him to the emergency department, because there is no sense taking history of a delirious patient in an OPD, right? He needs to be in the emergency department or in the ward. Second, if I'm seeing that patient in the emergency department, then I need to first question myself, forget the history. Is this patient stable? CAB, circulation, airway, breathing, is that fine? right? Am I going to see a patient who's going to collapse next? My history le raha tha and the patient had a flat line is a disaster in my medical career, right? So please don't do that, right? So if a patient looks not stable, the delirious patient is not stable, right? Focus on stabilizing the patient first. History can wait. Now, assuming that you have a patient who is delirious and has been delirious for a long time in your wards, and now you want to take the history, still listening to the patient comes first. Listen to this patient and listen to the caretaker who has some history to offer, right? So I repeat what I said. The question here really should be, is the patient delirious, stable enough to give history? If no, treat the emergency, then think about history. And when he's stable enough to give the history, and if you are in a position that history can be taken, take the history from the caretaker, not from this patient. That's why I hope that helps. Okay, so there are questions coming up. Purva, I'll follow your lead. Whatever question you read from, or whichever question you want me to answer.
So, how do we develop a rapport with the patient in case we don't understand their language?
There is a very universal language, smile. I am not exaggerating that, right? Start with that. Start with that, and I can tell you, कल शाम की बात है. I was talking to a patient of mine who, by the way, I'm talking on this format that you and me are right now talking on. I was talking on Zoom and I was teleconsulting a patient who cannot speak. Forget language, she can't speak, right? And she had pain at multiple areas, and she was trying to convey to me via a teleconference that where all is the pain. She has rheumatoid arthritis, and she was trying to explain to me where all is the pain, right? All you need to do is be in that moment and listen, right? This listen here doesn't necessarily mean what she's going to say. She might be able to point out. There's a lot of sign language which will happen. By the way, our communication, some of you might be from Quest, and I just happened to see that 2 days back, a lot of our communication, 70% of our communication is non-verbal. So you not knowing the language, of course, knowing the language has its advantages, but you not knowing the language, I still think the clues remain the same. Be there, be patient enough to listen. You are going to encounter, it doesn't matter what you're doing right now. Whenever you start practice, you are going to encounter patients who do not speak the same language that you do. There are but going to be people who can interpret that for you. Your confidence there matters. You being there matters. You're going to deal with foreign nationals who need interpreters. You're going to see all of that coming in your careers. The key remains the same. People understand that the person in front of them, if I'm the patient, I understand that the patient in front of me, you are interested in my story or not interested. If you're interested in my story, I'll make all the effort to explain it to you. But the moment I believe that you are not interested in my story, just because of language or whatever reason, I'm not interested in telling you the story. So the key remains the same. Have good eye contact, have a smile on your face, be there, wait, give them time, reassure them it's okay, I'll listen to you, I'll understand, and whatever I don't understand, I'll ask it again. क्या फर्क पड़ता है कौन सा तुम भागे जा रहे हो या मैं भागे जा रहा हूँ, तो सुन लेते हैं, right? Be there. That's the key. It's as simple as that.
Okay, so even I have a question. How do you make the patient feel comfortable enough about, talking about addictions or sexual history? How do we do that?
So it's going to be tough, but again, it nobody will talk about that. Those parts of the history which they are not comfortable about unless they are sure that they can trust you. And it's good that you asked me that question, because trust between patients and doctors, or medical students and their patients at that moment, is a multi-dimensional aspect. How many of you, let me just ask you this question, and you don't need to answer this question, but you just need to kind of raise your hand in your mind because I can see you. How many of you have felt irritated when some senior of yours, or maybe a consultant of yours, or someone, maybe the ward nurse, someone said, असे कपडे घालून वॉर्ड मध्ये यायचं नसतं, और समथिंग ऑफ दिस इफेक्ट आई एम ट्रांसलेटिंग इन हिंदी, कि ऐसे कपड़े पहन के वार्ड में नहीं आना होता. ऐसा बोला होगा आपको बहुत लोगों ने, कभी ना कभी तो बोला ही होगा, और नहीं बोला तो आप वार्ड गए नहीं, या फिर बहुत ही गुनी हो. ठीक है. सो अगर आपको ये किसी ने बोला है और आपको उससे बहुत चिढ़ आई है, तो आई वुड लाइक टू रीइटरेट दैट कि ऐसे कपड़े पहन के नहीं जाना हैज अदर वेज ऑफ इंटरप्रिटेशन. आई एम नॉट टॉकिंग अबाउट व्हाट क्लोथ्स वी वेयर इन आवर पर्सनल लाइफ, but when we are with patients, it does matter what you're doing, right? Your entire attire, it starts from there. The trust starts from there. I mean, think of it. I mean, you wouldn't trust me right now if I was to be shabbily dressed than what I am right now, right? That's as simple as that. So we trust each other on multiple factors, many non-verbal factors. So how you dress, how do you speak, is there empathy, are you concerned about listening to them, Are you judging them? This can be a very big one, right? Are you judging them? If patients who have things which carry stigma will always ask you this question: am I judging? So I have this patient of mine who is retropositive. Whenever he has some disease apart from what I can treat him for with, his first question to me is, please don't send me to someone who will judge me for this. And I keep on telling him, aisa nahi hai, people don't judge you. But maybe he has experiences, right? He's always afraid of this kid. Someone will judge him for being retropositive or having HIV, and what then? How will I describe my further symptoms then? He might not even have symptoms related to HIV when he has some other medical problem. But is he going to be judged, right? So all of these will come with experience, but I think they all will come also with very, 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 you might call me orthodox on this thought, but how you develop your own character in this field, right? How do you become the person that you envisage? We all have this idea in mind, what is a good doctor, like how does she look like and how does he look like, the great doctor in our mind. So if you want to become that, you need to start behaving like that, right? There's this one very interesting TED talk, I forgot the name of the speaker, and she has written a book on that, where she says that fake it till you make it. That's the title of the TED talk, very interesting one, where she says that if you want to inspire confidence, as one of the examples, you need to start behaving that way from day one. So if you want a patient to open up to you with history, which are personal stories or stigma related diseases, you need to behave like someone who they can trust. You need to start with that, right? So that's all I have to say on that.
What is your advice for final year MBBS students this year who do not have much exposure to clinics and patients?
Okay, so thank you for that question, Arnav, I guess. So thank you for that question. I was hoping someone should ask me that question when I was kind of thinking of what will happen in this session. So I would like to tell you this small story which might kind of give you the answer. I did my undergraduation from a private medical college, and I did my post graduation at AIMS New Delhi. And well, of course, I was happy with my college, with my medical college, but there were limitations. Despite being kind of reasonably sincere students that we were, uh, I had not seen a lot of patients about a lot of diseases. Now, I'm not saying this applies to all the private medical colleges today, but it does apply to a lot of colleges. And with COVID, it is applying to a lot of you also, right? What it did to me is, at that time in my career, it made me a little insecure. It made me think that, अरे मेरे को कुछ आता है कि नहीं आता सच में, right? But now when I look back at my career at this point of time, I'm roughly around 7-8 years into practice by now. I think that one aspect really has helped me a lot. You know what it gave me? It gave me this idea that I look up to my patients not as something I have a right to go and talk to, but as a privilege to talk to. I would want all of you to never forget this time happening to you. This time when you feel that you can't talk to patients should remind you. I started my talk with that, and I want to remind you, it's a privilege to talk to patients. It's not our birthright to talk to patients in medical colleges, right? So if you treat it like a privilege, you will keep on learning, right? So all my advice to you is, it doesn't matter whether you're in final year or not. As far as your exams are concerned, all your professors know that your batch couldn't see patients at this moment, but don't let that pull you back in your long-term careers. Your long-term careers, promise yourself that it is going to strengthen you further, because you will treat every new patient that you're going to see henceforward as a privilege. For example, in years gone by, months gone by, you would have easily seen and examined a patient of ENT. Today, when even if you join back, those of you in second year, if you join third year and go to the clinics, seeing a patient of ENT up close is going to be a big challenge. Every patient then that you see should be thoroughly examined. I can't walk away and say, "Baad mein dekh lunga." That won't happen. Treat it like a privilege. If you're a final year student, you will be an intern, and unfortunately or fortunately, you will get posted in COVID wards and many other duties. Every patient there, don't go thinking, if those of you in the government colleges, if you do an internship, don't go there thinking, मुझे बोला गया blood collection करना है तो मैं blood collection करके निकल आ जाऊंगा. Every patient there is a privilege. Remind yourself and then examine that patient thoroughly. Go to that patient, talk to that patient after you have done your work, because you need it. They don't need it, right? The table has turned, and I think it's turned for the good. It will make you better clinicians if you keep on dealing with every patient that you meet henceforth as a privilege that you have got.
Thank you, sir.
Okay. So, presenting the history and taking the history, are two different approaches. So how do we do both of these together since we only get attempt at history once?
Uh, Taking the history is what you do for yourself. I would always pay more attention to that part of the story. Once you know what you're supposed to talk, presenting the history is you presenting to the examiner or you presenting to the professor who has come to take that bedside clinic for you. That is a different skill set, right? For example, uh, when when you know a particular topic, few questions here and there you might be able to deal with, even if you don't understand, even if you don't know the right word to express a particular thing. But if you have not understood the topic at all, then whatever you say is going to be quite jargon speech. How much ever polished it might be, it is still going to be a jargon about you beating around the bush about what has happened to the patient. So my advice is forget presenting this story. Focus on understanding what has happened to the patient. Right. So while you're talking, that's what I said. While you're talking, it doesn't mean that you have to go through the pro forma and ask all the questions. That is a wrong approach. That's the way you present. So when I present the story, I present like my patient is a 25-year-old male, residence of this, and has an HOPI of this and a past history of this. But when I ask the story, when I ask the symptoms, I don't divide them that way. I ask him, tell me what has happened, and let him start wherever he chooses to start. And then I go behind. So, for example, the patient says, today morning, a patient comes to me and says, doctor, I have been having this backache for like 1 month. I listened to the entire story, and by the end of it, I'm convinced that he's talking about something which looks like ankylosing spondylitis. Unlikely that he's going to have this symptom for just 1 month. I asked him, how was the last year? Oh, I had this pain, but it wasn't so bad. Year before that, oh, that was really bad. That was really bad. Like, you're telling me 1 month. How long does it go? 5 years. His story was 5 years old. Now imagine if I have to write this down based on what I heard the first time. I might say HOPI is backache for 1 month. The reality is HOPI is backache for 5 years, which has aggravated since 1 month. That is the presenting part. But the analysis has to happen beforehand. And the analysis can only happen when you're listening to the patient and you're not bothered that time what are you presenting, you're bothered about what's the diagnosis, what are you trying to understand, what are you getting out of this patient at this moment. Right? So don't bother about presenting at this time or any time in your career. Bother about taking the right questions, taking the history well.
Okay, I think we'll just take one last question. We'll end it because we are out of time. So, so how do we convince a patient if they are not willing to take any medicine, and it's highly important for basically compliance?
Uh, Let me reverse the question. Why do you need to convince a patient? So could the person who has taken the question, would that person want to answer? I mean, I wouldn't mind having a dialogue.
Yes, sir. It's me. I asked a question.
Hello.
Like recently, I have been to a camp, and over there, there was this old lady, and she wasn't accepting to take the medicine. Her BP was like really high, 180 by 102. But then we all of us tried convincing, and then she was like no. So that's why I wanted to ask that
So
question.
why do you think she was not ready?
She was like, no, I'm fine. I'm like doing all my day-to-day activities, all well and good. So I don't want to take the medicine. I don't find any difficulty.
Yeah. So why do we want her to take the medicine at all?
Um, because it is necessary for her to take, sir.
What is necessary? She has no problem, right?
Yeah, but if she
But
does
it
it,
can
like
further lead to
it
other
might
problems, right?
become a problem in the future.
Right. And if it occurs that she will have further problems, taking this drug, let's say for example, we are going to give amlodipine. Do we guarantee that taking this drug she will never have that problem again?
No, I don't think so, sir.
So thank you for this dialogue, Roshni, right? Roshni?
Yes, sir.
Yeah,
Yes,
so
sir.
thank you, Roshni, so much. Again, I completely agree with you that it's our duty to try and inform the patient. I'm not very convinced about this idea of convincing patients.
Okay.
We have to understand, this is my personal belief, and a disclaimer in place that this is my belief. I don't think we are in a profession of convincing anybody about anything. We are in a profession which is a blend of science and art. The art is how we talk, not how we convince. The science is we need to know what are we offering, and we need to offer that very clearly to the patient. There are a lot of patients you are all going to come across throughout your career who do not want to accept the therapy that you have to offer. They might either want to, as in case of this grandmother who said that I don't want to take this particular medicine, I don't have any symptoms. There are going to be those who will say, you say this works, but I think no, this doesn't work. Maybe some other therapy works, some alternative medicine which you have no clue about works. So they want to try out some herbal medicine, they want to try out something else. Your job is to stay within the limits of science. Within the limits of science and law, of course, I can only tell the patient that this is what can happen to you if you don't take the medicines. If I give you the medicine, the chance comes down by this much. I cannot promise more than that. So, for example, if I give a person who is hypertensive, antihypertensive, I might be reducing the chance of coronary artery disease by 5% or 10%. That's about it. Am I ever going to prevent coronary artery disease completely? The answer is no. So we shouldn't lay too much focus on our own science also. We shouldn't see our science as an all or none law. ऐसा होता तो हम दवाई देके सबको बचा लेते. We can't do that. So we have to be very, very clear about stats. This will happen with your career. I'm not asking you to do that right now. But we need to have that dialogue with our patients. We need to inform them what will happen in future. Give them the complete natural history as you see and let them take a call. It is very important that the patient has the choice. Our job is not to influence, or our job is not to persuade. Our job is to inform. That's why it's not called a convinced consent. It's neither called a persuaded consent. It's called a informed consent, right? So we need to inform the patient, give them the enough know-how to take the decision. But that has to be done very meticulously. We have to give all the information that you need to give, right? With career, there is a reaction to what you asked me. Early in the career, all of us are bothered. Why are patients not listening? Somewhere down in residency, unfortunately, a lot of us flip and we start thinking or believing patients will never listen. Wrong flip. Be aware of that, right? All of you are very young, so be aware of that flip coming in your careers ahead. Don't make that flip. Don't make that flip in your mind. They're never going to listen, so why do I bother? Always make your complete effort to tell them everything that they need to know about the disease, and then offer them the choice that these are the options in front of you. If you choose to do this, I can help you this way. If you choose to do that, I can help you this way. If you choose not to take your medicine, I can still stand by you. What we can do is, let's start with lifestyle modifications. Why don't you come back tomorrow? I'll check your BP again. Maybe 2-3 visits to you might be able to actually convince her. Who knows, right? Don't give up on them. Don't ever give up on them, but don't even force them, right? Stay with them. That's where trust is built.
Yes, sir. Thank you so much. This is such an amazing answer.